something that would be quite useful, and I hope it is to yourselves too. What it does is it talks about the initial assessment and management as one would be expected to do as a day one consultant, certainly here in the United Kingdom, and it also touches on some of the topics of definitive management of these injuries. So what we're going to do is we're going to review the assessment and management for a day one orthopedic consultant when they're faced with a multi-ligament injury, and also discuss some of the literature pertaining to the definitive management of such injuries. So knee dislocation is essentially a disruption of the tibiofemoral articulation, which occurs typically in any direction that involves at least 2 ligaments, but perhaps more. Very significant injury, dependent on the energy of the mechanism and the type of mechanism that's involved, and has a potential for vascular injury, can happen in up to about 40% of cases. These injuries are quite bad, and often, if mismanaged, is up to a 20% amputation rate, as this has been demonstrated in the well-known LEAP study. So this is just an X-ray. In fact, this presentation was meant to be somewhat interactive, and I appreciate we probably can't engage ourselves in an interactive fashion on this forum. But
talk to you can ask them questions; they'll come back to you. No worries.
Oh, can we? Okay, lovely.
Yeah.
You know, this is just an example of an X-ray of a 16-year-old child who was involved in a motorcycling accident, and came back with, and this is how they presented to A&E. Can anybody appreciate any subtleties that may pertain to a multi-ligament or a dislocation type injury here?
Guys, so by all means, interact and see what you can see and describe your X-rays.
Sir, may I?
Yes, of course.
Yes. Sir, one of the findings I can see in the AP and as well as the lateral view is the patella alta.
Yes.
Also, in the lateral view, I could appreciate there is patellar articular condylosis.
Okay.
And
there is subluxation of the.
So guys, you know, I mean, I am cringing. Remember we said this is an X-ray of adult knee showing AP and lateral view, meaning that this is an isolated injury. We can see that the patella is higher up. It's alter.
Okay, sorry, I just started with the findings.
Come on, guys.
So whoever, is it Mr. Dr. Raz?
No, it's somebody called S.
Yes. The thing is, we're talking in the context of a knee dislocation. I appreciate what you're telling me about patella alta and about the chondrolysis, which probably you can't really comment on an X-ray. Is there anything that strikes out to you in the context of knee dislocation or multi-ligament injury?
There is posterior subluxation of tibia on femur. It's a grade 2.
Well done, very good, yes. So you can see that the posterior tibial condylar line, if you were to match it up, it doesn't match up with the posterior femoral condyle. So that is perhaps suggestive of a PCL type injury. However, what's even more subtle is this. There is actually a slight asymmetry of the medial tibiofemoral compartment as compared to the lateral side, which indicates to the fact that there may also be some sort of medial collateral ligament or medial sided capsular injury. Can all of the delegates appreciate what I'm talking about here?
If you put your arrow onto the picture, you can show them, yeah?
Okay, so if you look here in close-up, this is the view. If you go back, it looks fairly innocuous. 16-year-old child, doesn't look pretty much everything. There is some patella alta. Perhaps the only thing we can see is that this posterior tibial margin does not line up with the posterior femoral condyle, and that suggests that there may be a PCL injury. But what's definitely more interesting and more subtle is the gap here is more than the gap here. And if I zoom in, you can appreciate that more. And the point of bringing this slide up is the fact that such multi-ligament dislocations can present in such a subtle manner. So there is a lot to be gained from the radiographic analysis and the clinical assessment of these patients. In fact, if you look at that same patient's MRI scans, you can now see the bone bruising, you know, the lateral collateral ligament injury, the medial sided injury that there is, and also the high signal that is going on in the PCL. So the purpose of that was basically to explain to you that these injuries actually sometimes present themselves fairly in an innocuous manner when you look at their radiographs in the first instance. But you should have a higher index of suspicion, especially in the context of high mechanism injuries. Granted, however, these are extremely rare injuries, 2 to 229 per million orthopedic injuries. The wide variation would suggest that they're very, very rare. And the reason it's important to have a high index of suspicion is the fact that 50% of them self-reduce before the time you get to see them. It happens more in males than they do in females. So you can think about these injuries in perhaps in kind of three ways. You have the high energy mechanisms, crush injuries, road traffic accidents, motor vehicle accidents, and they constitute for about 50% of multi-ligament injuries of the knee. Then there are the sporting people who play sports who have massive twisting injuries when they're playing football or rugby or cricket or whatever, and then they sustain multi-ligament injuries. And then there are the cohort that we often see, and probably Mr. Shah will agree that certainly in the demographic that we work in, multi-ligament injuries tend to happen in high BMI people who have much more weight than their ligaments and their tendons can support, and then they sustain such multi-ligament injuries. They're the ultra-low injuries. In terms of classification, initially and originally the classification was devised in terms of the direction of the instability, which is perhaps difficult to apply in the clinical context. And the most prevailing system that we use today is the Schenck classification. This is a anatomical classification that is based on the nature of the ligaments that are gone. So KD1 will be where you have a single collateral ligament injury. KD2 when you have both PCL and ACL or two ligaments gone. KD3 is when you have bicruciate plus a collateral ligament, and then you can divide it into KD3N, which is for a bicruciate and medial sided injury, or a KD3L, which is a bicruciate and lateral sided injury. Then you also add arterial injuries and neurovascular injuries as sub-designations. KD4 is when all four of the ligaments, i.e. both cruciates, both collaterals are gone, and KD5 is with an associated fracture. And this seems to be the most useful classification system that we use in our clinical practice to try and guide management and assess severity. So clinical assessment, okay, it starts always with an ATLS protocol, particularly so in the context of a high mechanism injury, because this may be part of a multifocal trauma process. Then, once we've established that the patient's airway is good and the primary survey is undertaken, and we're established that this is the isolated secondary survey, secondary injury, then we go on to focusing on the knee and essentially ensure perfusion, reduce, and stabilize. That's the first thing to do. Okay, often these knees can be grossly deformed, particularly in the context of a high energy KD3 or 4 type injury. And you often see this medial puckering of the skin when the injury mechanism is such that it has invaginated and buttonholed through the medial structures. You may see swelling and hemoarthrosis, particularly if you look in the popliteal area, there'll be bruising going up and down, crossing the skin crease. But often these things are not necessarily always there as clues. This is an example of a clinical picture where you can actually see the medial side of the knee, and you can see the puckering and the skin crease, which is quite evident from the fact that it has a pretty nasty medial sided dislocation. Vascular injury, up to 40% of these patients can have a concurrent arterial injury. They may present with absolutely hard signs of a blocked vessel, such as pallor, coolness, maybe a pulsatile hematoma suggestive of a pseudohemarthrosis type thing, and delayed capillary refill, and as we know, the absent distal pulses. Again, this is just a quick review of the anatomy. Gentlemen, could someone just shout out the numbers of what they see on here? What's number 1, guys? This is the back of the knee we're looking at. This should be fairly straightforward.
Posterior tibial nerve.
Let's see. Tibial nerve, number 2.
The common peroneal.
Common peroneal. Number 3 is the sciatic. Number 4.
Superficial peroneal.
The sural nerve, I think. It's the sural nerve. It's the lateral communicating branch of the sural nerve.
That's good. Lovely. Lateral sural cutaneous branch. Number 5 is sural communicating. 6, guys?
6 is the sural nerve proper.
Sural nerve proper. Well done. Number 7.
7 is the, I think the medial communicating branch. I'm not sure.
Absolutely. Well done. And what's 8?
Is 8. The popliteal artery and the vein.
Good. 9.
9 is the geniculate artery, the lateral geniculate artery and artery and vein. Sorry.
Good, good. Number 10.
Number 10 is the medial geniculate artery and
Good. Okay, now going into the musculature, what's A?
A is the medial head of the biceps femoris.
Semitendinosus.
Of the
Remember that's the medial side, right? This is the medial side.
Okay, yeah.
Yeah.
Sorry.
What's B?
B is the semimembranous.
Good. C4?
C is the
Gastroc from the medial head.
Medial head, lateral head of gastroc. Sorry, that's my mistake. That's an error on my part. Sorry. It should be the other way around. And then the biceps femoris. Okay, thank you. This is again to illustrate the vasculature that you see in the back of the knee. Okay, so vascular assessment. The arteriogram is the gold standard. Modern non-invasive methods such as CT arteriogram has showed a very high sensitivity and high specificity to pick up arterial injuries in the context of knee dislocation. However, the question is, should we be undertaking angiogram in everybody? Should we be undertaking an angiogram in people with hard signs only, i.e. clinically apparent evidence of vascular injury? Now, often it is not as clear as this, and patients are in between these two extremes where they have no vascular injury or they have absolute vascular injury. This is what one could see when you undertake a CT angiogram, certainly in our institution. This is what we would be expecting to find. But the current thinking is that there is a latent period of vascular injury. You can have either a vascular injury when there is a flow limiting lesion in the acute post-reduction period, i.e. something has literally blocked the arterial flow, or perhaps something that we're more commonly familiar with is a delayed and intimal tear which still allows some flow, and you can still have peripheral pulses and good capillary refill, but then that often evolves and progresses to a full-on blockage, or you may have secondary ischemia from a thrombotic event in the intravascular compartment or in the intravascular space. So something that the literature pertains to now is having this method of continuous monitoring and assessment to decide on how to undertake CT arteriograms for our patients. So if you've got hard signs, then yes, you can go on an on-table angiogram and undertake an exploration in conjunction with a vascular surgeon. You may have a situation where you've got pulses are present, but they're weak and there's some slowing of the capillary refill. Then what we tend to use as an objective marker is an ankle brachial pressure index, simply where you put the blood pressure cuff on the arm and then you put it on the ankle and then you work out the difference between the two and work out a ratio. If the ratio is less than 0.9, then this is an indication for undertaking arteriogram, as it may be suggestive of an intimal tear. If you've got distal pulses are present, but you're still suspecting, a bad vascular injury, or if there is asymmetry, you keep monitoring the ABPIs over time to see if there is any change. And if the ABPI drops below 0.9, then again, you can consider undertaking a CT arteriogram and then discuss that with your vascular surgical colleagues. Nerve injury is the other common problem. So up to 40% of cases, there is a common peroneal nerve injury, and this is perhaps the nerve that is primarily most affected. And these are usually traction injuries from the significant varus deformity that happens and the stretch on the lateral side. Anyone want to comment on this X-ray? Hello?
Yeah, we can hear you. It's just that everybody's gone to sleep. I don't know why.
Hello. Yes, sir.
Go on then.
Sorry, sir, I didn't get your question.
Anybody wants to comment on this X-ray? Can you see anything
sir, this is
relevance
sir,
on
this
this X-ray?
Sir, this is a planned radiograph of a skeletally mature patient on AP view.
Yeah.
showing the Seagon type of fracture.
Is it a Seagon?
It
No,
Where
that's
do you
the
normally see the Seagon
tibial
in
spine
the
rupture, I
Seagon?
think.
It's a fibular
That's-
collateral ligament avulsions, I think.
That's
Yeah,
correct.
that's a-
So what is this sign called? This is actually known as the arcuate sign. So
okay,
in the
sir. Tip of fibula. I'm sorry.
yeah, no, that's okay. So this tip of fibula, is something known as the arcuate sign, and often this can be missed. But again, we should have a high index of suspicion, and something such as this on an X-ray is highly indicative of a lateral-sided injury, which may include the lateral collateral ligament and the posterolateral corner, or either. Often these patients will present with a peroneal nerve injury, which is a neuropraxia in nature. Again, the MRIs of that same patient will show of the same patient with the X-ray. You can see that there is a significant lateral-sided injury with invagination of the structures into the articular surfaces. And in the bottom corner here, with the white arrow, you can see that there is that broken fragment. So 40% of nerve injuries, common peroneal nerve. If you have a common peroneal nerve injury in the context of this, then suspect lateral collateral or posterolateral corner injuries. So what do you need to do about these patients? In the emergent setting, foot drop requiring to prevent foot drop orthosis to prevent equinus. As a part of the procedure, exploration and neurolysis may be undertaken at the time of definitive treatment. And if there is no progress in nerve function by the stage of about 3 months, then certainly in our institution we would consider referring to the local peripheral nerve injury unit. So initial management, always close reduction, and immobilize and reassess. So we tend to use external fixation as the initial part of the management during the ATLS, after the ATLS has been undertaken, before we can plan definitive management. So irreducible joints, such as the buttonhole of the medial femoral condyle, as we talked about before, these things may not necessarily be amenable to close reduction, and often you have to do a arthrotomy to see if we can reduce the joint back out of the MCL, as one can see on this picture here. So definitive management. So the definitive management is something that is we talked about in the literature, but is probably mostly based on level 3 and 4 evidence. The type of injury is so rare that there aren't any hard randomized controlled trials or prospective studies to really inform our decision. But certainly this is a very useful paper that talks about the pearls of definitive management of multi-ligament injuries. And largely what we know is that operative management is better than non-operative management in terms of functional outcomes and return to sport. While the paper suggests that repair versus reconstruction, we don't really know if we should undertake repairs in the early stage or if we should just straight go for reconstruction. There is now emerging evidence to suggest that reconstruction is always better. And certainly if you're going to wait up to 3 weeks or more, then at that point, scar tissue is such that identifying any of the anatomical structures become very, very difficult. And at that point, perhaps we should abandon the thought of any sort of repair, but undertake a reconstruction. However, if you're before the first 3 weeks, then it's always a good idea to try and repair what is repairable, any bony avulsion fragments or any of the collateral ligaments. In our institution, we like to use the concept of internal bracing quite a lot, where we internally brace the structures with direct repair to allow it to heal. But again, if you're getting to the stage where this is now 3 weeks down the line, then perhaps repair is not a good idea, and you should consider reconstructive options straight off the bat. Okay. Early surgical intervention is definitely better, and the 3 weeks seems to be the cutoff for to define patients between early and chronic cases. So this is another paper which is even more recent than the one I've just shown you, and there is some suggestion that if you are in a situation where you have grade 3 or more injuries, then you can consider undertaking early repair of the collateral ligaments, and then definitive surgery later on. And a staged approach to this actually does yield some good outcomes. It may not necessarily be completely feasible to undertake a shank type 3 or type 4 injury in the reconstruction in the same sitting. So in summary, this is a rare injury. It has a very high index of suspicion. Neurovascular injury to a common peroneal nerve is very common, and one corner or a lateral collateral ligament injury. Initial management includes ATLS, and then the principles of reducing, reperfusing the limb, restrict, and once you've done that, you can undertake imaging, reassess, and plan definitive management. If it's within 3 weeks, you can consider undertaking some repair procedures and then undertake a definitive staged reconstruction later on. If it's after 3 weeks, then a staged reconstruction will yield the best outcomes. Thank you.
So thank you. There are a few guys here on the forum at the moment. There's Kazimir and Sufyan here who do multiple ligament reconstruction or the same sitting. But for the exam purposes, guys, you need to understand, and I think everybody's agreed, you need to be safe and you need to answer the questions properly. So if somebody shows you an X-ray that you think is causing a dislocated knee, or you think it's a dislocated knee, you must be safe. You must say, after ATLS triage, I will assess the patient. So I will, what is called a span, scan, and plan kind of situation, which means that we will assess, we will then data across it, we will then do some imaging, and then do a plan for the patient. If there is a vascular or a neurological injury, you guys need to make sure that you have to have that sorted out, because vascular injury is an emergency. We know we did brachial plexus, and in brachial plexus, unless it's an open injury, we don't need to repair it and wait for it to come. If it doesn't come back, then maybe send it to, refer it on for somebody else to reconstruct it. Certainly at the time of when you're doing the lateral side, you may look at it and see what you want to do. It's the most you can do it is tag it in the exam. You must remember, nerves you can't repair. Well, you can, but you can't repair it in the exam. You can tell them that I will tag it and get a specialist to help me. Okay.
I agree with that sentiment. Yeah.
Sorry?
No, I agree with that, Michelle. Yeah, I mean,
because
to be safe
in our country, if you talk about repairs, that's it, your exam's done, then the examiner's having fun with you. So also, a vascular injury is important. You must have a suspicion of vascular injuries, and you must use the ankle brachial index to help you and guide you. In reconstruction, I think I've seen lots of evidence which shows that you need to sit on it and need to plan your procedure. You cannot do all those together, but if you want to, it has to be at 3 weeks or more. Otherwise, you lose all mobility in the knee. I'm not sure, but that's not my experience, because Sufyan or Kazim or you can tell us what really happens if you do them early or late. But the general consensus is to sit on it and plan it before you go into it blindly, like I said. And again, in the exam, I don't think so that many people will ask you how to do a repair of a PCL or ACL. Kazim, maybe Sufyan can tell us that. But the best way is to be able to negotiate yourself around the questions. I think Fahad has given you enough information for you to be safe when somebody's asking you questions. So we'll take questions now, and Fahad, get ready for bombardment, as they call it. Any questions, guys? So everybody's gone quiet now.
I mean, while people are thinking about their questions, Michelle, just as a debating point, I agree. I mean, there are some surgeons. I know Rob LaPrade from America. He certainly advocates doing all the repairs in one go, and there are some strong arguments, and some of his reviews of his analysis of his patients that suggest that they do well. So there is a school of thought that think that undertaking repair all in one go allows you to return to sport earlier and rehab much better and quicker. But the counter argument to that, and perhaps if you're being asked in the exam, what would you do, then it'd be good to be able to show an insight into the pros and cons to both. And the cons, I would argue, are that there's an increased risk of arthrofibrosis. The surgery would take much longer, and actually. The literature would suggest that having a staged approach does yield some good outcomes. So, one could argue that may be a safer approach for the patient.
So I mean, I know both my boys in Liaquat National. They do it together, and therefore they do all the construction together. So because surgeons operating, maybe them it may be easier. I do remember reading quite a lot and says if you do them early, osteofibrosis?
Yeah, I mean, certainly if you know, reconstruction is better than repair. We know that. Apparently, outcomes are better according to the first paper that I showed, according to the big Western names, and they suggest that, you know, repair with reconstruction within 3 weeks results in better outcomes. But there is this counter argument about osteofibrosis as well. But you know, it seems to be that the cutoff is about the 3-week mark.
So now,
Obviously, you don't want to operate on day one. You may want to rest it for about 2 weeks, and then within the second and third week, you consider undertaking a definitive management. I think you have to be a pretty skilled surgeon to be able to undertake all of that in one go, in the context of like a KD3 or a KD4.
yeah, no, I understand. I mean, this is because where multiple surgeons, and remember, Mr. Iqbal and Mr. Kundra used to do them together. Like,
Yes, yeah, it's a very good idea to.
Is much better. But
Yeah, I agree.
Fahad is taking time off. You must make sure that we get what he said. So can we ask him questions? If you're not asking questions, can we make sure that our microphone is turned off, please? Yeah.
I have a question.
Yeah.
I have
Can you tell us what your name is so that?
I'm Kazim. I'm a second-year resident from Indus Hospital, Karachi.
Assalamu alaikum.
Walaikum salam.
Go on, ask your question.
Yeah, my name is Kazim, and I'm a second-year resident at Indus Hospital, Karachi.
Yeah.
I would like to ask one question. I missed that part. What's if it's an open multi-ligamentous injury? What would be a plan then?
If it's an open ligament injury, so for me, again, it will be assess the patient via the ATLS protocol. I will ensure that the patient's primary survey is secure and take a quick secondary survey to ensure that there is no other injuries. Assuming that that would be an isolated injury, I would treat the patient within the context of any open injury, which will involve immobilizing the patient, undertaking antibiotics, getting soft tissue coverage, and then coming and planning for the definitive management of the ligaments once we've got soft tissue coverage. Now, you know, where I am, we don't necessarily get to see these type of injuries that often, but I suspect the management of open fractures and ligament injuries in the context of an open ligament injury should be pretty similar.
So yes, I mean, not so long ago, we had a patient from the third category, which was overweight patient, and he was only walking when he tripped from the stairs, and he tore everything off. It was a 5 or 4 or whatever you wanted to call it, like with vascular and an open problem. So we did a fixator on him, and we got at that time, because it was a weekend, we couldn't get the team in, so we got the referred him to QE, and all they did was put him in a nice little brace. One of those PCL braces, and that did well for him actually. And then they came back to do something permanent in about 4 or 5 weeks' time. But in the meantime, he was managed conservatively. Although he was an open fracture, he was clean, tidy up, and antibiotics and soft tissue covers was done before anything else was done for him. So I think that's the answer to that question, isn't it? Like, any more questions?
So for open injuries in the UK, we have, maybe you guys can access this as well, it's something called the BOA and BAPRAS open fracture guidelines. I don't know if you guys are aware of it.
But the BAPRAS criteria, yeah.
That's correct. So I think the principles of managing any open injury in the context of high trauma should be undertaken according to the BOA and BAPRAS guidelines. And then once you've done that, you can add on the reduce, reperfuse, and immobilize principles for a multi-ligament injury. Perhaps the first priority would be to get soft tissue coverage, reduce the infection load, and once that has settled, only then can you come back, maybe 3 weeks or whatever down the line, to consider ligament reconstruction, either in a staged or all-in-one procedure.
Thank you so much. Thank you.
Any more questions, guys?
Sir, one question. Sir, in a global ligamentous injury, after we cannot repair or we are attempting reconstruction, the priorities are the first ACL and PCL reconstruction, after which what do you do next for the repair?
So this is a question that I was really dreading that you guys were going to ask me, because I've looked at the literature and there is no sequence that I know of that is highly recommended or there is a consensus. Some people will argue that you should undertake the peripheral ligamentous reconstructions first, i.e. the collaterals or the posterolateral corners or the posteromedial capsules to prevent any rotatory instability, and then undertake the bicruciate together. Now you take the bicruciate together because if you do the PCL on its own in the presence of ACL, then you may, the tension, the reconstruction tension might be such that you detension it. So, and then there is also this other school of thought that says that you should undertake one cruciate and one collateral together. So to be honest, I don't really know what the right answer is in terms of sequence of ligament reconstruction repairs. But what certainly does make sense is to undertake the, for me at least, to undertake the collaterals and the posterolateral corners first to ensure rotatory stability, and then you come back and do the two cruciates together. Again, that might be completely wrong thinking, but and there is definitely difference of opinions onto the different sequences of reconstruction.
One associated question like this also.
Sorry, you must tell what your name is so that Fahad knows who's talking to him. Like, isn't it? First tell your name and then ask the question.
My name is Dr. Muzahir, and I've completed my training and I'm just preparing for the exam. I just wanted to get us a question in our exams that a patient is having two ligament simultaneous injury, like he is having an MCL plus ACL.
Yes. So in that situation, it is entirely reasonable to undertake those two things together. And that I have been involved in cases where we have done that in the past together before.
Guys, don't forget, there is a variant classification. There is one ligament, two ligament, three ligament, four ligament. When you talk about multiple ligament, four ligament, that's a different story. But two ligaments together, collaterals with an ACL or collateral with a PCL, or posterior lateral corner with an ACL, that's quite easily done. Those two bits are done easily. It is when you get more than three, then when you get into trouble, like, isn't it?
That's right. And you have to understand that in the presence of an MCL injury or an LCL injury, if you just reconstruct the ACL, you're not really controlling the valgus varus nor a degree of rotational instability, which puts a lot of strain on the cruciate reconstruction.
I'm sorry, sir, to intervene here. Just what some people just advocate the fact that sometimes you actually go for a cylinder cast or something for 3 weeks or more and let the nature take the course and let it heal by itself, and then delayed repair of the ACL. What do you think about that?
I agree with that. So like I said, there are outcomes. The literature from 2009 would suggest that if you try to undertake definitive reconstruction within 3 weeks, outcomes are better. But the paper by Jiang from China in 2015 would suggest that good outcomes can be achieved with delayed reconstruction as well. And in fact, you know, the reality is that by the time you've let the patient settle down, most of these patients return back to your clinic in about 3 to 6 weeks. So for me, yes, you can put them in a plaster cast and wait. And in fact, you may find that the MCL heals up to a certain degree and all you're left with is a reconstruction of an ACL. So that is certainly a very good strategy.
So can I do it now? Be careful in the exam. You cannot say, some people say that. As Fahad told you 2 references. Maybe you need to name names and say this is what is referred, because if you say some people say, well, I mean, people that I read like me will ask you questions that you might struggle. So don't make a statement in the exam as some people say. You know, if you haven't got any evidence, you can just say evidence suggests from the Chinese papers or something like that you can do them later. You know, that defends what you say rather than just making a statement. Because
I think the best way to answer that question is the literature suggests that outcomes are best when reconstruction has been undertaken within 3 weeks. However, there is also literature to support that a delayed approach to reconstruction yields just as good outcomes.
Yeah, so that's a very political, very safe statement for the exam.
Thank you, sir. Thank you so much.
I've got a question again. Kazim here from Inter Hospital. How frequently do you start the rehabilitation process after reconstructing the multiligamentous injury?
So that's a very good question. It depends on. So if you've undertaken everything in one setting, then I think it's reasonable to start rehabbing them straight away and be fairly aggressive with it, because you want to minimize any risk of arthrofibrosis from such a strong surgical insult. Now, the rest of the rehab depends very much on the staged approach and what ligaments you are reconstructing. generally speaking, most of the patients that will have an MCL reconstruction or with a concurrent PCL, they tend to get a brace in my practice, and then they have some gentle movements, focusing firstly on stage 1 to get full extension and symmetrical to the other side and reduce swelling. Stage 2 will be to focus on range of motion, so you try to achieve range of motion as best as you can. Stage 3 will be to try and improve muscle strength and proprioception. Stage 4 will be return to activities. Stage 5, return to sports. So I think in terms of rehabilitating, you apply those concepts, which have been described by someone called Don Shelbourne and Leo Pinczewski, to your ligament injuries.
Limo?
So my question.
Thank you.
This is Uzair from Ghurki Hospital, Lahore. I wanted to ask, is there any difference regarding the approach in skeletally immature patient in terms of cruciate or collateral injury?
Oh, so this is a very difficult, this is a question. I mean, to be honest, my experience with pediatric ACLs is very limited, but I have recently been involved in an ACL repair. So what I understand from the literature is perhaps you should consider these patients in terms of their Tanner grading. So Tanner 2, which is pre-adolescent children, who have a lot of growth left, probably in their 11s and 12s. Those are the patients where you should endeavor to undertake a physeal sparing approach. Patients who are, within their pubertal period or just, passing their pubertal period, then in those people you can undertake transphyseal fixation. Now, in the context of collateral ligaments or postlateral corners, it's not so much of a problem. It's more of a problem when you're talking about cruciate ligaments. And I think the Tanner staging is quite useful for us to kind of guide our methods for reconstructing the cruciate ligaments and when in the context of skeletally immature children. But the principles largely stay the same. Try and reduce the damage to the physis as much as you can. Try and keep your tunnels long and as vertical as you can, and if possible, try and be epiphyseal in nature.
Sir, can I ask a related question to this?
Mm-hmm.
Pediatric ACL, can anybody advocate extra
articular reconstructions? Yes. So there is some literature to suggest that undertaking an extra articular reconstruction in addition to cruciate ligament injuries have yielded good outcomes. The author of this paper forgets me. It's a female author from America, and she has shown a series in JBJS America where a lot of her patients have been treated with an extra-articular repair in addition to their cruciate injury. Now, if you're going to do an isolated extra-articular repair and no cruciate reconstruction, that I really don't know the answer to that question. But in my mind, to undertake an extra-articular reconstruction in addition to a cruciate ligament repair or reconstruction in the pediatric population seems to be a good idea.
So what about internal bracing these pediatric patients and then putting snake venom such as PRP and all that kind of stuff?
Yeah, so I'm a great believer of internal bracing. Only recently have I been involved in a 12-year-old child where I had a femoral avulsion ACL tear where the postlateral bundle was intact, but the AM bundle was gone. And that resulted in a pivot shift injury. He had a Segon fracture, a lateral collateral ligament high sprain, and also a PCL sprain. When we got in there, we found that actually the two bundles were fairly well thick, and it was literally an avulsion injury. And he was skeletally immature. So I managed to make my internal bracing tunnel on the tibial side entirely epiphyseal, whereas on the femoral side, it was a transphyseal tunnel. It was very, very narrow, 3.2, only for the flip cutter. And that then allowed me to pull my repair sutures through and also the internal brace. On this occasion, I did not undertake a lateral extra-articular tenodesis such as a Lemaire's procedure because I had the internal brace. So, I don't know if this is right or wrong, but the internal brace for me was what an extra-articular tenodesis would have done. And they work really well. There is evidence to suggest that fiber tape has been going on with 9 years follow-up in the foot and ankle world. And in fact, we have at least 2 or 3 years follow-up of use of fiber tape in many other constructs within the knee. So it stands to reason that we should be able to use it as an internal brace construct for our cruciate ligament injuries as well.
So guys, I mean, if you have no question, will one of you summarize if in the exam somebody asks you, Who's doing the exam? Was there? I think you're doing exam from Gurki at the moment, isn't it?
Yes, sir. I'm also giving exams. I'm from Mayo Hospital, Lahore, sir. Muzahir, my name
All
is.
right. Okay. So from Mayo Hospital, then why don't you summarize it? So if the examiner asks you that you have a patient we think he's got a dislocated knee, so how would you manage it? Can you do it so everybody can understand that they can answer this in the exam the way we want them to answer it? Yeah. Can you?
So who are you asking to, Dr. Uzair or me?
Anybody can answer. Just we want a summary. So in the exam we can vomit out all these words we just speak now, so that we can be safe and we can look like we're educated and we know what we're saying. So what would you say if the examiner shows you a dislocated knee X-ray?
For your reference, I can recommend you guys a really good paper, Journal of American Academy 2015. Can you see me, guys? Still?
Yeah.
Yes.
Let me see if I have the reference with me.
So if you send me the reference, I'll put the paper on the forum, yeah?
Okay. I'll have to, how do I send it? That's the
It's all right, okay. You can stop share.
Okay. Stop share. I don't know how to do this.
It doesn't matter. Let go. So just send me the reference on the phone and I will pass it on to other guys, yeah?
Okay, we'll do it.
Yeah, so guys, you need to tell me very quickly, 5-minute answer. The 5-minute answer, what would you say to the examiner if you showed you an X-ray with a dislocated knee? I have one person who's doing an exam to answer this question.
Can I try? It's
of course.
Rafiq.
Tell me who you are and where you're from and you can answer.
Sir, my name is Mohammed Rafiq and I am from Karachi. Civil Hospital, Karachi. So if I found a case of knee dislocation initially, I will assess his neurovascular status, then will reduce and stabilize. If the patient pulses are fine, then I put the patient under the observation. But if my ABPI are not fine or less than 0.5, then I will consider for the CT angiogram and look for any vascular injury. And if the knee is not stable and there is global instability or is open, then I will stabilize the knee with the help of external fixator. And if any finding in the CT angiogram, then I will give a call to the vascular surgery team for possible repair.
Okay, so remember the words that Fahad used, hard sign and signs, okay? So what you can say is somebody comes with a dislocated knee, assuming that this is an isolated injury and there is no other part of it and he's ATLS stabilized, I would look at the patient for hard signs and vascular problems. If there's no hard sign, I will look for soft signs by doing a brachial ankle index. Once that is safe, my plan would be to scan and plan. Do you understand the word?
That is a brilliant term, span, scan, and plan.
Yeah.
You guys should always use that. And it applies to many things, not just multi-ligament, it applies to
everything.
Articular fractures.
You must use the word span, which means you either put a fixator on it or you put a plaster on it, but what you're trying to do is keep the joint where it should be. And then scan, do your MRI scan, CT scan, vascular studies, whatever you want to do. And once you've seen all that, it gives you enough information for you to plan what you want to do with this future. So this is what you have to use in exam. You have to use the terms that the examiner understands. And once the examiner asks you, well, how will you manage it surgically? And you say, again, the same question. This is the answer. Assuming that it's an isolated injury patient is ATLS triage, there are two thoughts of management. Either do them early or do them late. So I have experience or no experience, and I have experience of seeing them in Pakistan where they are done late because the patient comes late and the management and the investigation, everything takes time. But there is evidence to say that early repair or late repair gives the long-term results. And then you will say that what would you repair? And you say if it's a 4 or more injury, I do the periphery first and come back to both ligaments, ACL and PCL together. Or if it's an isolated injury or an injury with 2 ligaments, then I repair them at the same time. These are all safe answers. You can't be a specialist in everything in the exam, but you have to know basics and be safe in what you're answering. I think this is a very safe answer that you can give. Is trying to find out what it is, how you can support it, how to investigate it, and what to plan it. And then you have to know what type of injury it is. Do this, okay? Is everybody clear with that? You must not mess up on this particular topic in the exam, because now that we have given you the answers and how to, and a very nice presentation by Fahad, then you guys need to make sure then you don't get stuck on this particular topic in the exam. Is that okay?
Sir, can you hear me?
Yeah, yeah.
Yes, sir.
Sir, this is Dr. Fahad from Lahore. My question is that for multi-ligament reconstruction, what donors can we get? Because we have only gracilis and semitendinosis. If we also need to reconstruct the PCL and the collaterals and posterolateral corner, so what are the donor options we have for the patient for reconstruction?
So this is dealer's choice. I don't think the source of the graft is an issue. You can use allograft, you can use hamstring, semi-T, gracilis, you can use peroneus longus. In some contexts you can use quadriceps and BTB. It is dealer's choice. I don't think it matters too much where the graft comes from. Certainly in the western part of the world where we have perhaps a slightly easier access to allograft, that would be the primary choice of our tendons. But people have been known. Finelli uses peroneus longus split half tendons. People use semi-T and gracilis. What is perhaps useful to understand that your PCL grafts should be quite thick and long compared to your ACL graft, because there is a high risk of failure rate with those if you use thinner grafts. Apart from that, I think you can use whatever is available to you.
So you can use the same side, you can use the opposite side, right? And your boss, Amr Qureshi, he once suggested, which was very well. I did not know much about it by the time, but I've read quite a lot now. Is young children have their parents give them grafts.
That's correct.
Yeah.
So a lot of the guys are now doing that. They're taking parental or first degree relative grafts to use to protect their own grafts for future use or for their function.
Yeah, and in Pakistan, hopefully soon we will have a graft bank. But at the moment, there are no grafts that you can have in Pakistan. So that's a bummer, as you.
But one thing is certainly for clear is if you are going to use allograft, there is a recent drive towards using internal bracing. Because one has to understand the basic science. An allograft will take much longer to integrate with the host bone or host ligament attachment or whatever else have you, perhaps in the region of 18 months, as compared to autograft, which will probably integrate within 6 weeks to 3 months, or maybe at the latest 6 months. So for those cases, you should always consider using internal bracing to protect that reconstruction. That seems to be a recent drive and something that most soft tissue knee surgeons are practicing here, where if you're going to use allograft, you should internally brace them.
Okay, so guys, we've taken Fad's time. Is there any more questions?
Yes, sir. One more question.
Okay, name and where you work first. So name and where you work.
I'm Dr. Fahad from Lahore.
Okay, which hospital in Lahore? Sorry, I've been...
in Children's Hospital nowadays. Before I was in Saudi.
Right.
Now I'm in Children's Hospital.
Okay.
Well, I want to ask, after vascular reconstruction, after how much time we can go for ligament reconstruction for injured knee?
Very good question. I think that you have to consider the vascular injury on its own merits. So if this is a situation where you've had a vascular surgeon undertaking a full-on posterior approach to the knee, and they've done a bypass of the popliteal graft, you're going to wait for the soft tissue and the skins to close. If you're getting to the stage where you're now at the 3-week mark, you might as well wait until all the soft tissue and scar tissue have settled down and undertake a reconstruction in a staged procedure. If you're within the 3-week range, and you feel that soft tissue recovery and the vascular injury has settled, then you can undertake it then. But I don't know, and I'm not aware of any literature to suggest that there should be a gap or a delay, but I may stand corrected. I'd have to look into that.
So the answer for the exam is that no vascular surgeons will repair your knee unless you stabilize it for him first. You can't use a plaster, so you have to do a X-fix. So you span it. You span it for the vascular surgeons to repair what they have to repair, and then once that's healed, you can always come in. You can always take the span, fixate it out and put a hinge on it to get some movement there, but the vascular injury comes as a priority. You must also understand that vascular injury is sometimes picked up late, and therefore they end up with compartment syndrome and they have multiple anatomies. You would not want to do anything until all that is healed, but you need to span it and wait for everything to heal before you come back again. That's a safe answer for the exam. There is no evidence or literature to suggest that while the vascular surgeon is doing his repair, you can do your ligaments together. I think what he would prefer for you is to be out of the way. All you have to do is stabilize it by putting a fixator, and you must also make sure your fixator is not in the way of your imaging or your vascular surgeon, because they get very upset. I remember my earlier days when I was a new consultant, as Fahad puts it, first day consultant. I did put a fixator on, and it was right bang where the vascular surgeon wanted to do. So he called me, and it was 3 a.m. I had to come in and change the fixator for him, But yes, make sure that what you do is not obstructing anybody else. Everybody happy?
Yes, sir. I have a small question.
Thank you.
Go on then.
Hello.
Yes, tell me who you are and where you're from.
Sir, it's Dr. Rafiq from Civil Hospital, Karachi.
Yeah?
Dr. Rafiq from Civil Hospital, Karachi.
Go ask your question.
I just want to know that in a young patient, if in one group we are doing the reconstruction of soft tissue injuries in a global ligamentous injury, and in other patient we are doing the arthrodesis in young patient. So
arthrodesis.
Yes, sir. What's the difference between what's the result of patient satisfaction?
I think the treatment modality of undertaking an arthrodesis in a young child with a multi-ligament injury is perhaps something we should not be practicing.
I totally agree. For a young child, we should not do arthrodesis. I know cost comes into thing, and speciality comes to it. But I say this in Pakistan, and everybody hates me for this. We must not do polygamy. We must not do everything. We must try to share our practices. We must find patients specific in that particular area, in that specialty, to start referring patients to them. We should not do surgery that we are not used to, not comfortable with. Certainly, arthrodesis in a young child is bad.
I think to consider arthrodesis for a multi-ligament injury in the context of an exam answer is a no-no.
That's correct. In the exam, you cannot answer that question. You cannot say that you were doing arthrodesis for a young child with multi-ligament injury.
A lot of patients with a multi-ligamentous injury who are coming from the peripheral areas, most of the doctors advise them for the arthrodesis, and they spend a lot of months at their home. Then they come with the arthritic joint, and they say, sir, now we came to Karachi, and we heard of this sports surgeon, so for the ligamentous reconstruction. So what to do with these kind of patients?
So you must educate people around you. You must educate people around you. You must tell them that they need to send their patient early. You cannot tell them that you're a magician, you have fairy dust, and you can put your hand and it'll get sorted out. It's communication skills. I do a lot of training in communication skills. You have to tell your patients the real truth. You can't tell them, Baba, sab kuch theek ho jayega. That's the very bad statement. I was recently in one of the hospitals doing a live surgical course. The patient was told by a surgeon, in front of me, not the boss, but somebody else, that sab kuch theek ho jayega, pareshan hone ki zarurat nahi hai, sawal puchne ki zarurat nahi hai. That is a bad approach. You must be honest with your patient. You must tell your patients you've come late, therefore I cannot cure you, but I can certainly help you. Right? But arthrodesis in a multi-ligament injury is bad.
I think in this young patients who've got multi-ligament injury and who've already got degenerative changes set in, a long discussion has to happen with the patient about the outcomes of arthrofibrosis and stiffness afterwards. But perhaps in these patients, a staged approach is a very good idea. So you do the ligaments that you think are necessary, reassess them and see what their range of motion and things like, and then come back and add to it on a basis.
And if such a patient who presents to you with the degenerative changes and multi-ligamentous injury a lot of months, means 8 months, 10 months before, so would you advise him for the arthrodesis? Young patient with degenerative changes and multi-ligamentous injury?
No. Sorry, let me answer that. Yeah, no. The answer is no. You will do whatever needs doing, in the sense that if the ligament that is missing, you need to try to repair that, do a release, and get the physios to work with you. Like Fahad said, it has to be a stage procedure. By putting an arthrodesis on that patient, you have burned all options. That you have no choice, anything to come back to. So you can always come back and do a joint replacement or an arthrodesis in the future, depending on the age of the patient's problem. But to suggest that as primary treatment, I would certainly not agree with that at all. I'm not sure what Fahad's views on that is.
I agree. I think certainly here, in the context of an exam, that would be the wrong answer to give.
Okay. Yeah, thank
The
you.
realities in Pakistan may be different. I appreciate that. But, you know, the most sensible middle of the ground approach is aggressive early physio rehab and a staged approach to ligament reconstruction to try and optimize function of that knee as best as possible. By actually giving the patient an arthrodesis, you're actually, you know, basically sentencing the patient to having a, you know, no knee function at all.
Even if patient is having degenerative changes.
Depends on the degree of degenerative changes, and for that reason, it may be worthwhile giving the patient a staged approach. So you rehab them, get their knee moving, improve their range of motion as much as you can, treat them with a brace, then you reassess and do whichever ligaments that are most important. If it is predominantly rotatory instability, then you consider the collaterals and the posterolateral corner or the posteromedial. Then rehab him again and see how the knee progresses and improves. And if there is still element of cruciate instability, then undertake an ACL and then reassess again. I think that would be my more labored approach than simply jumping into an arthrodesis in any patient.
So do you remember Hippocrates? Oh, he said, do no harm. By arthrodesing his knee, you are causing harm. And you're taking the easy option. In Pakistan, the patient has got a livelihood and earning to make. So if you do an arthrodesis for him and he has no function, you have taken so many options for him to work with. The best option is to do a staged procedure. You bring them, physio them, do surgical releases, do wherever ligament needs to reconstruct, and see what happens. You know, you and I are not the ultimate decider. It's Allah Ta'ala at the top who decides who's going to have what kind of knee, isn't it? But by fusing and arthrodesing the knee in the first instance, you have given him no opportunity at all, none whatsoever. And if I was an examiner and somebody sold that exam answer to me, I certainly know Zaki Saab from Indus Hospital, not Indus, from Liaquat National. He will kill you on the table. You know, he will slowly and smiley at you and then not let you pass the exam. You know, so make sure that you make statements that I know you may be wanting to do an arthrodesis, which is an easier option, but I think it's certainly not a fair option.
Sir, can I have one more question? My
Yes.
name is Dr. Muzahir again. Can you, Dr. Fahad, can elaborate a bit more on internal bracing?
Internal bracing. So essentially, internal bracing is the use of a synthetic ligament. It works in the same concept of a seat belt. So for example, the simplest way is if you think of doing an ACL reconstruction, when you pass your graft and you've got your femoral tunnel and your tibial tunnel, you take the fiber tape, which is a highly cross-linked polyethylene mesh tape that you actually use in conjunction with your hamstring graft or BTB or quadriceps graft, whatever graft you want to use, and you secure and tension that in slightly less tension than what you would secure your cruciate autograft reconstruction with. So the idea basically is that most of the load is taken by your cruciate ligament or your cruciate reconstruction. However, if there is any excessive load which may predispose that graft to rupture or failure, that extra threshold beyond which the force becomes excessive is taken over by the fiber tape or the internal brace. So that's why you always make sure you tension your fiber tape or internal brace in full extension. And I personally, when I tension my reconstruction, I do it at 30 degrees of flexion. So those are the two things. You don't want to tension your internal brace in the same tension as your reconstruction, because there is this argument of stress shielding. So, you know, if most of the load is being taken by the internal brace, then there may be no scope or physiological loading of the tendon or the reconstruction to heal or to take with the bone. So internal brace is basically a secondary protective measure to prevent increased failure rates.
So you're saying that we should not tension the actual allograft too much, and we should put the protection, actually the polyethylene or whatever.
No, the other way around. The other way around. So for example, if you're doing a hamstring ACL, you put the graft and the internal brace together, okay? And then you put the knee in full extension and tension the internal brace separately with an independent swivel lock or staple or screw or whatever have you. Okay, once you've done that tension, then you bring the knee into 30 degrees and then you tension your ACL as you do. The tension through the ACL will always be slightly higher during the tensioning process than what you will achieve with the internal brace.
So the exam answer for internal bracing, remember guys, it is done to augment whatever you're doing. So if you're using a allograft, which you don't use in Pakistan, then you definitely would put an internal bracing with it, or you can do an external augmentation from an extra articular repair.
To be honest, it may be worthwhile just actually staying away from the concept of internal bracing for the exam. It is quite
very controversial.
Yeah.
But if somebody does ask you, it is done for allografts mostly, and where you feel that the graft is not strong enough to withhold whatever pension you're going to.
So my practice is internal brace allografts, internal brace anything that's less than 7.5 for ACLs. And if it's less than 7, then I do an 8-strand graft using a semi-T and a gracilis together, because I do a double suspensory technique.
Okay, and remember, guys, you don't have to repair everybody. You can put them in a brace. You know, the famous Indian cricketer, you know, what was that called? Raj, what was his name? You know, the left-hander, the one who won the World Cup for them last time when they were in India, Yuvraj Singh. So he had a ACL and PCL gone, and he lived all his life playing Test cricket and one-day cricket with a brace. Right, so surgery is not the option to everything, answer to everything, but certainly one that gives you rehab and quicker back to return to sports. But this man played all his sports all his life professionally with a brace. You know, so you can hold these things, but then they have complications later on. Remember the exam answer, the safe answer, and also make sure that you don't answer something that you get yourself into trouble. Certainly after leases on the multi-ligament injury, if you answer that in the exam, you will get into trouble. You will get into trouble.
Mr. Shah, can you hear me?
Great.
So I think we've had enough of all these discussion arguments. If nobody has questions, I'm going to end this meeting. But the meeting also videotaped, so I'll put it on the forum and see if you guys can make use of it. But thank you very much. And thank you, Fahd, for joining us. And it was something I was told in Pakistan last week, when people ask too many questions, that means you have created interest. Like, people go quite...
I was getting a bit worried there, but thank you, guys.
It's not interesting.
Thank you.
Thank you very much.
Thank you, sir.
Guys.
Thank you. Thank you, sir.
Thank you. Thank you so much. Thank you.